Hi, good evening, everyone.
Oh,
Welcome back to another session of webinar on this Wednesday. With me, I have Dr. Wong my colleague for
hello.
today, who is a breast surgeon. Actually,
Yeah.
she's an endocrine surgeon. So we just take it too broadly that she's a breast surgeon, but she does a lot of endocrine work also, like thyroid and everything else. And previously, she actually also gave a very interesting talk on parathyroid, an organ
Yeah.
that we actually sometimes forget. And then I'm, of course, Dr. Betty Tay. I'm the founder and CEO of Beating Hearts. And without further ado, Mewan, maybe you would like to start.
All right. Thank you. Good evening, everyone. Thank you for joining us. First, I want to thank Betty for inviting me again
Yes.
to give a talk in this webinar. I'm very flattered and thank you. So I decided to give a talk about breast cancer this time, considering the Pink October is coming soon. So I'm sure you will face a lot of, not a lot, a few breast cancer cases or breast cases, and they might ask you questions that are pertaining to what we will do when you refer cases to us. So yeah, let me try and share my slides. Okay, so uh, okay, let me try and see whether I can put it into uh,
What
the
the
the whole
format is this?
screen.
This PowerPoint?
Sorry,
This PowerPoint?
it's PowerPoint, but the PowerPoint that I wanted to share somehow I can't seem to put it in a presenter view. Present
Yeah?
like this. Wait.
No.
So present connect.
Is
Wait.
okay? I think
Can see
that's the stream.
or you're seeing the
That's
presenter view, is it?
perfect. Perfect, Eddie.
Sorry.
Correct. Perfect, Eddie.
Perfect already. Okay. So let me start by talking about the breast cancer. It's the number one cause of cancer among females in Malaysia and also in most countries. Um, our latest data about incidence of breast cancer is from 2012 to 2016. It's about 34.1 per 100,000 population. So in Global Can 2020, this is estimate for Malaysia is about 32.9 per 100,000 population. So actually, this incident hasn't changed much for the past 20 years. So in year 2000 also, the rate is also about 36 per 100,000 population. So what does it mean? It means that the risk of getting cancer, breast cancer in a lifetime for females in Malaysia is about 1 in 20. 20 females, one will get breast cancer in their lifetime. Um, it may sound scary to us, but then the incident is actually higher in the UK and the US. So in UK, the risk of getting breast cancer in a lifetime is about 1 in 8. And in US, the risk is about 1 in 4. We do have males with breast cancer, but it's about 1% only. So the peculiar thing about us in the Asian countries or Malaysian women is we tend to present at an earlier age compared to the females in the Western countries. So in Malaysia and Singapore, approximately 50% women are diagnosed before the age of 50. And but in Western countries, only 20% of women diagnosed for breast cancer before the age of 50. And also, Malaysian women tend to present at the later stage of breast cancer compared to women in Singapore and the Western countries. Um, this is the incidence rate of breast cancer in Malaysia. So you can see that in year 2007 to 2011 is about 30.4, and then it's pretty much the same from 2012 to 2016. So, what are the signs and symptoms of breast cancer? Usually, many females come in and present with a lump, but breast cancer lumps tend to be very hard and it's fixed and or irregular. Sometimes it appears like a thickening mass in the breast or axilla. Some may come in with the enlarged lymph nodes in the axilla. Some may come with nipple discharge. Particularly, it had to be bloody or watery in nature, or some of them would present with nipple retraction, and some, a very small percentage, present with scaly skin around the nipple. So they may present with some dimpling of the skin, especially near the cancer area, or the skin, the whole breast, the skin become like the skin of an orange. So we call it pure orange. And any change in size and shape of the breast by right should alert any females to come and seek attention, medical attention, or get it investigated. So, how about going to detecting breast cancer? Usually, we advise populations at risk of breast cancer to start screening mammogram. Ideally, yearly, starting at 40 years old. Our Malaysian guidelines still advise for 2 yearly screening mammogram for females starting at age 50. So this yearly starting at 40 is something just recent, especially in the US and the UK. So we still advise, many of our doctors also still do clinical breast examination, ideally annually for women more than 40 years old, and 3 yearly for younger female. And we still encourage females to do breast self-examination. Um, you, the best time would be every month. When you just examine your own breast, around the breast and the underarm area. You can start at age 20, and the best time to examine yourself is the last day of menses, or if you are postmenopausal, then you just fix yourself at the same date for at same date each month. So the thing about screening is for women who can practice occasional breast cell examination, they can actually detect a lump about 22 centimeter size. But if they do it regularly, they can detect a smaller breast lump up to 1 centimeter or less in size. But if they go for mammogram, then we can detect a lesion, smaller lesion less than 1 centimeter. And if they do regular mammogram, because we have previous mammogram to compare to, we can actually detect even smaller, less than 5 mm lesions in the mammogram.
Wow.
So, yeah. So this is why we are encouraging every woman to go for a screening mammogram because of this. Because the earlier we can detect it, the better we can treat it. So about doing early breast cancer detection, we have several tools to assist us in imaging in detecting breast cancer. The commonest one would be ultrasound breast. Obviously, this is the most uh, preferred mode of imaging for every woman out there because it's painless, it has no radiation risk, it is very safe. You can do it 100 times and still doesn't cause any problem to the patient. It is ideal also for patients with dense breast. But then the sensitivity of detecting early breast cancer, especially the DCIS, is much lower compared to mammogram. So the utility of ultrasound breast is only good at detecting solid lesions and leads and cysts, and it is a good assessment tool for this lesion, which is more than 1 centimeter in size. So the thing about solid lesions and cysts, they can be benign. So when we detect lesions like this, it can cause unnecessary anxiety to the patients. But for us in the breast surgery clinic, the specialized breast surgeon, we still have very good use of the ultrasound because it's very good for us to guide biopsies. Okay, so ABLE's automated breast ultrasound is something is a new kind of ultrasound whereby we put a big plate above the patient, and then we set uh, some some we put it on and then it will just take several automated images all over the breast, throughout the whole breast. And then the radiologist can just screen through and look at the images like a mammogram or a CT scan afterwards. So it doesn't need to be operator dependent. So this is the latest, one of the latest imaging modality that we have here. So about mammogram, mammogram is the the preferred screening tool that we we advise for patient, whereby you need to, there's two plates to squeeze the breast, and then we take an X-ray of the breast. Sorry,
You okay?
I'm okay. I'm okay. Sorry, talk too much already. So anyway, I mean, ideally we would want a very not so dense breast whereby we can see very tiny lesions. But even for very dense breast, we can still detect lesions, but it's a bit harder. But we still encourage people to go ahead with the mammogram. So one of the setbacks that I encounter when I see patients in the clinic is that a lot of them, they don't want to do mammogram. They say it's painful, they worry about radiation risk. But at the end of the day, screening mammogram can detect microcalcification, which are indicators of DCIS. So you have to explain to the patient to weigh the benefits of early detection of DCIS compared to the risk of radiation, because at the end of the day, radiation for mammogram is much lower compared to a standard X-ray. So nowadays, we use 3D mammogram or breast tomosynthesis. So whereby we don't need to squeeze the breast so hard, and we take serial images of the breast like a CT scan. So you can reassure the patient by telling them that nowadays our plates are contoured. It's not flat like a piece of paper or cardboard. And it can cause a lot of discomfort or pain to the patient when doing the mammogram. Now, the latest technology I've heard of about screening imaging breast is this breast CT scan, whereby you do like a standard CT scan for the breast, and you don't need to squeeze the breast anymore like a normal mammogram. But at the end of the day, we don't have this yet in our country. They are just starting to promote it, and we still don't know about the accuracy or sensitivity of the machine. So it's one of the reasons why it's not widely adopted yet. But the company is trying to promote that, you don't need the hassle of squeezing the breast and it doesn't cause any pain. So we have to wait for a few more years and see whether this thing will pick up or not. So the next imaging is MRI breast. There are some people that actually ask me about MRI breast. Is it useful as a screening tool? So MRI breast is only useful if the patient is very young, because the breast is very dense, so we cannot see the lesions properly. We also routinely use MRI as a screening tool for patients who are BRCA positive, the BRCA gene positive, whereby they have 90% risk of getting breast cancer. And also those patients who had fillers, injection silicones into the breast. So we use MRI instead of the standard imaging ultrasound mammogram for this kind of patients. But the drawbacks about doing MRI as a screening tool is that it's very expensive. And at the end of the day, it's still not very sensitive in detecting microcalcification and DCIS. And also it can have false positive, whereby it can cause unnecessary anxiety to the patient again. Okay, so many patients will come and ask what to expect when seeing a breast surgeon for a breast lump or lesion. They may get very anxious, then they will ask you what's going to happen to them. So usually for us, we will do a standard breast assessment. We will do a background check. We will ask about the duration of the breast lump, any associated symptom like pain or any axillary lump or any nipple discharge. And we also look out for risk factors such as family history, because it does have something to do with the gene, the BRCA gene. Okay, then we will examine the patient and assess where is the cancer, how big is the lung, whether any axillary lymph nodes are enlarged and palpable or not. Then we will ask them to go for imaging study, particularly mammogram and ultrasound breast. And if the imaging confirm that there is a suspicious lesion in the breast, we will advise patient to go for biopsy. So biopsy is only recommended when we found a lump that is deemed suspicious on the ultrasound mammogram or on clinical examination. So how we do breast biopsy is what is breast biopsy actually? Breast biopsy is actually a important procedure to decide how to treat breast cancer. So we use an ultrasound to locate the suspicious lump. We will give local anesthesia, then we will pass a slightly larger needle to take some of the tissue out and send it for testing. So many patients will ask, doctor, if it's you suspect cancer, why can't you just take it out? So I will explain later why this is this is not recommended. And I also have many patients who thinks that doing a biopsy will make the cancer spread and cause stage 4 cancer. That is completely wrong also. Okay, so that is my setback number 2. Many patients doesn't want to do biopsy when I try to counsel them for a biopsy. So, so again, this is how a breast biopsy, we have 2 ways of doing it, either using an ultrasound or we use a mammogram to guide us how to take the tissue. So before, just a little bit about breast cancer treatment, I would like to emphasize that breast cancer treatment has really, really progressed and evolved so much for the past 20, 30 years. Okay, in the past, surgery is considered the mainstay of breast cancer treatment, which is why many patients ask, why can't you just do a surgery and remove the lump? That is acceptable 100 years ago, but it's no longer acceptable nowadays because they now with advanced epidemiology, medical and genetic study, this is very, very untrue. Surgery is no longer considered the mainstay of treatment or curative treatment anymore. So current studies now is we are aiming at eliminating there are even studies nowadays aiming at eliminating need for surgery altogether for some certain breast cancer types. So in the past, like 1800s, okay, the old theory, 1894, one size fits all. The more you cut, the better your cancer control, then you will reach a curative treatment. So in the past 18,000, the Halsted mastectomy is the golden or standard treatment for breast cancer. So, and this, as we move on, the late 1958, Bernard Fisher has started this saying that breast is actually a systemic disease. So before diagnosis, before presentation, cancer has already assumed to be already disseminated. So surgery is no longer the most important modality of treatment. Systemic therapy is equally important as surgery to cure breast cancer. So nowadays, we have even evolved even more in saying that breast cancer is not a single disease, it's a spectrum of diseases. We have so many types of breast cancer, okay? And axillary lymph node is just a prognostic indicator, it's not a barrier, meaning that if I don't remove any enlarged lymph nodes in the armpit, it does not change the patient prognosis. Okay, so and in the future, there is a possibility giving systemic therapy may replace surgery. So nowadays, what we now know about breast cancer is that unlike other solid cancers, breast cancer has many types. We have hormone receptor positive, the estrogen progesterone positive, receptor positive breast cancer. We have HER2 overexpressed breast cancer. We have triple negative breast cancer. And each subcategory of this breast cancer respond differently to different medication or systemic agents, or you can say chemotherapy agents. Okay, and each subcategory of this breast cancer has different prognosis and overall survival incidence, and they have different response to the systemic therapy. Okay, so you have to alert patients. Surgery and treatment need to be planned and directed to each of these subcategories. No single patient with breast cancer is the same as another patient. Okay, which is why I would want to emphasize again the importance of breast surgery prior to surgery. Okay, doing a breast biopsy is important to determine which type of breast cancer, which cancer subtypes the patient falls under. Okay, and it also gives me additional information about how aggressive the breast cancer is. Okay, I mean, confirmation of the breast biopsy in regards to benign or malignant is just help me to extend how much I want to do the extent of breast surgery. Do I need to remove more of the breast lump, or do I need to do a mastectomy? That's it. So nowadays, breast cancer treatment, we have so many multiple algorithms and treatment pathways to treat breast cancer. And each of the algorithm and the pathways is catered to either it's early breast cancer or whether it's advanced or metastatic breast cancer, which subcategory of the breast cancer it falls under. So breast treatment no longer limited to just whether it's operable or advanced breast cancer. It's no longer limited whether doing surgery, chemotherapy, or radiotherapy alone. So, and prediction of recurrence and prognostic factors also no longer limited to the surgery report and the imaging report. Okay, so current trends, our aim of treatment nowadays, we rely more on dynamic and changing factors, such as response to the chemotherapy agents. So I just shared this Malaysian guideline to treat breast cancer in 2002. If you are in a center where you have very limited access to advanced medication and treatment, then you can still follow this, whereby you divide the breast cancer, whether it's early operable or whether it's advanced. So, but then again, nowadays, we have multidisciplinary approach to breast cancer treatment. It is important and a must in our current practice for breast cancer. It is no longer a single person decision. Even at the initial clinic visit, I cannot just tell the patient, oh, you go for surgery and you will be well. I cannot do that. Okay, it involves so many people. It involves surgeon, it involves radiologists, oncologists, pathologists. I need to ask the pathologist what type of breast cancer this is first before I decide what treatment to give the patient. And breast cancer is also important to counsel the patient and reassure the patient that treatment is in line. Delaying chemotherapy doesn't mean that it's delaying the treatment. Okay, so which is why I go back to my another setback. Okay, I have many patients after doing a imaging, mammogram, ultrasound, and biopsy, and I tell them you need to go for chemotherapy. Many of them will tell me I don't want chemotherapy. But then again, like I mentioned just now, giving chemotherapy is actually more important in more aggressive breast cancer, and it is actually the current management consensus. So what are the aggressive breast cancer subtypes? There's actually two. One is the HER2 enriched breast cancer, another one is the triple negative breast cancer. So the aim of giving chemotherapy before surgery is to, number one, is to shrink the breast tumor size. Okay, then it enable me to avoid mastectomy. I can cut a smaller chunk of tumor instead of cutting out the whole breast because the lump is too big. And the second one, more importantly for me, is we aim to achieve complete pathological response, meaning that if we give chemotherapy and if the cancer has completely disappeared on the resected specimen, it means that the patient would have a lower local recurrence rate and a higher overall survival rate. So if I remove the cancer after neoadjuvant therapy and there is residual cancer on the resected specimen, so we can plan better to give a second line of therapy to prevent recurrence. So it simply means that the residual cancer is more aggressive and it doesn't respond well to the first line chemotherapy. So, and you have to remind the patient, recent chemotherapy has actually less and more tolerable side effect. I actually have many patients during chemo, they actually go to work. They don't feel anything. So it's actually more tolerable. It's not as terrible as everybody thinks. So at the end of the day, to treat breast cancer is for us is dynamic risk and prognostic stratification. Means that we always assess patient response to the chemotherapy. Okay, and we examine again, maybe doing the breast ultrasound again, and decide how much the cancer has shrunken during the course of the chemotherapy. And like I mentioned just now, we would want the cancer to completely disappear when we do the surgery and remove the lump after the chemotherapy. So complete pathological response means that there is no more cancer in the specimen, receptor specimen, and also in the axillary lymph node after the chemotherapy. Okay, and this is confirmed by the final pathological examination. Okay, it indicates successful chemotherapy and also improve overall survival and disease-free survival. Okay, um, although complete pathological response is a good sign, it does not guarantee the patient is completely cured from the cancer. Patients still need regular monitoring to detect recurrence. And unfortunately, recurrence doesn't necessarily always come back in the breast. It can come back in the lung, in the liver, in the brain, in the bone. So these are the ones that we cannot we cannot really predict. So maybe just a little something to remind everyone about the stages of breast cancer. At the end of the day, if you come in with early breast cancer, like a DCIS, a stage 0, survival rate is 100%. But if you come in at stage 4, whereby the cancer has already spread to distant to the lung or the liver, then the survival rate has actually gone down to 28%. But then again, chemotherapy nowadays or targeted therapy nowadays, we can still treat this stage 4 quite well. So the patient would have a little bit longer overall survival. So the staging for Malaysian women, this is our data, our local data. If you compare 20 years ago and 10 years ago, patients who presented with the stages, the later stages and the early stages is still pretty much the same. So it's fairly, we still have about 20% who come in with the stage 4, and majority of our patients usually come about stage 2 and stage 3. So a little bit something about surgery for breast cancer. What we usually do is we still do a wide local excision for the cancer, whereby we remove the tumor and also a rim of normal tissue surrounding the tumor. And at the same time, we remove the axillary lymph node in the armpit, just to make sure, just to stage the patient and to see how many lymph nodes are involved for cancer. So the resecting the specimen, they we have so many ways of remodeling the breast after removing the specimen. So we call it oncoplastic surgery. But one thing you need to remember, the thing about removing just the lump and not the whole breast, the patient need to go for radiotherapy is actually mandatory. So this is to reduce the risk of recurrent cancer growing back in the breast itself. So the conventional radiotherapy that we give, we call it external beam radiotherapy. It basically just means that applying a high dose of X-ray to the breast, and it's usually done after the surgery, about a month after the surgery. So a lot of people ask what are the side effects of radiotherapy. So it's like a sunburn. So some patients may experience some itching, but more commonly some redness. And if the dose is too high, they may get blisters on the skin. And when they go for the radiation, they may feel hot around the radiation area. So I do have some patients who complain of feeling very tired after the radiotherapy. Some with pain and some breast swelling. Very rarely, I never heard of a rib fracture, inflamed lung or the heart, or secondary cancer like a sarcoma. Usually, I think this one happen if we give too much dose of the radiation to the breast. Nowadays, uh, we have this newer technology. We call it intraoperative radiotherapy, whereby I can apply direct radiation to the breast, the cavity of the breast after I remove the lump. So it's an alternative to the external beam radiotherapy. The radiation is concentrated at the tip of the applicator. It has lower side effects and complication compared to the standard external beam radiotherapy. But this technology is only applicable to certain breast cancer, such as those with hormone positive, very small breast cancer, lump, and yeah, such as that. So in summary, this is my last slide. Advancement in research and clinical study has enabled us to progress from performing mastectomy only and concentrating about saving life to now we can consider oncoplastic surgery and saving the breast. We don't need to remove the whole breast for every patient. And also, even those with stage 4 breast cancer already metastatic everywhere, the overall survival is actually improving because of advancement in the medication, targeted therapy for breast cancer. So, but then again, early presentation of breast cancer is still very important for especially to, those who wanting to go for breast conserving surgeries. The smaller the lump is, the easier for us to save, to remodel the breast after removing the lump. So, which is why the ongoing support for breast cancer awareness campaign and the Pink October is still very strong, because we want to empower patients to come forward whenever they feel a lump. But when doing surgery, we still adhere the oncologic principles of breast cancer, and we would want to achieve a good cosmetic outcome. So that by careful planning treatment with considering all the subcategories of breast cancer is very, very important. But then again, we have rapid advancement in medical treatments and technology. I will not be surprised there will be some time in the future, far future, there will be a possibility of omitting surgery altogether for breast cancer in the future. Maybe for now, only for very early breast cancer patients. So that's my last slide. Sorry if it's a bit confusing and too long.
So May Wan, you're
Yeah.
saying you may be out of job soon.
Yeah. Which is why.
I-
So I must make sure I retire first before this happens.
Okay, I see
Yeah.
Jeff. I see Jeff. Jeff maybe want to join us because
Yeah.
reconstructive surgery. So,
Yeah.
but of course, less and less people are going for mastectomy, right?
Yeah.
And so
Yeah.
that's less job for Jeff now. So
Yes. Yeah.
soon it will be less job for you. But can
Yes.
I ask you, which I always found it very curious for me,
Yeah.
when a mammogram detect a very small lesion, like 1 millimeter,
Mm.
a few millimeter, lah, let's say 4 or 5,
Mm. Yeah.
do you then define where is the lump? Can you really feel the hardness when you open up?
No, actually I cannot. Usually for this kind very tiny lesion, I have to estimate and measure from the mammogram images and 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 cut, which is why for very tiny lesion, I need Vicky to help me to put in a wire to guide me where to cut.
And this guidance is from mammogram, or is it from MRI or ultrasound?
Mammogram.
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 Okay.
Mm.
So the other question is, truly, is it that painful, this mammogram? I've done mammogram before. Yes, you need to.
I've also done mammogram before. I think it's mainly very painful for very small breasts. Because the
Not big breast.
uh
Not.
so because you just need to feel the discomfort, because you feel the two plates squeezing your breast,
Yes,
you know,
yes. There is
Yeah,
some discomfort. It's not without discomfort, but it is not
yes,
that painful.
painful, yes. But I guess if the technician really squeeze your breast up to paper thin, then yes, you will feel the pain more. Yeah. So
But it's
nowadays,
very
yeah,
long, I
nowadays,
think. Yeah.
sorry,
Not very, not prolonged. It's a few minutes, less than maybe a
correct,
3 minutes.
correct.
So, right? Yeah.
Yeah. So in the past, the old conventional mammogram, they really do need to squeeze it paper thin in order for the radiologist to see something. But our nowadays, I think most of the hospital nowadays are using the 3D mammogram. So we don't need to squeeze it so hard anymore. So which is why I say it's really not that painful. It's just discomfort, yes. Unless the technician really squeeze it.
Yeah.
Squeeze the
I
breast.
don't, I mean, it's like over drama, lah. If you say it's really painful after
I
all.
do I do have several patients who actually told me after their first mammogram they don't want to go through it anymore.
Yeah.
So
I've also had patients saying that, but
yeah,
I don't think that is so painful. I
yeah, correct. I
I
agree.
think it's more painful.
Yeah. Maybe discomfort lah. Like you say,
Okay. I
discomfort.
want to
Yeah.
ask you, you said that the percentage of breast cancer has remained somewhat the same over the
Yeah.
years.
Surprisingly, it's been
Yeah.
the same.
So
Uh
can we
yeah.
say that it might have dropped? Why I say this
No.
is because the awareness is greater, the screening is higher,
Mm,
but it's still the same. If
yes.
awareness and screening is more, then it should
Yes.
go up, right?
Yes. So ideally, I would see that we should see more early stage, the stage one, stage two, more percentage and lesser stage three, stage four. But if you notice just now the slide, it's been the same. So I don't know because I have met a few well-educated patients,
Oh,
denial lah, basically. They think that it's nothing, or some doctors when I examine and it's not. I actually have some patient who is under treatment, some wound dressing for a year and still don't know what is going on.
oh, no. This denial of having cancer or breast cancer uh, is across the board, doesn't matter
Yeah,
what profession. I've seen
yeah,
a nurse coming with really like gangrenous breast, okay? I could smell
yeah.
a mile
I
away.
still see it once in a while. I
Yeah.
still do. Yeah.
And she was a nurse. I don't know how anyone could have lived with her in the house because
Mm,
from so far away I could it's the smell was so foul. And I've
yeah.
also had so you're actually setback number 3, which is patients
Chemotherapy.
starting chemotherapy. Okay,
Yeah.
I worked in a center whereby I do a lot of echoes for patients chemo
Yeah.
for breast,
Yeah.
especially when they're on target therapy. And I
Mm,
found that there are still many patients, okay, that no matter how you speak to them, they have a fear of the word chemotherapy. And
yeah.
and correctly, as you said, that chemotherapy is not what it used to be.
Mm,
See a lot of people on
correct.
chemotherapy, on target therapy, they lead a normal life and they go
Yeah.
back to
Yeah.
work. Okay, of course you lose hair, but you
Yeah.
have a disease and your hair can
Yeah.
grow again. It's like cutting
Yeah.
your really
It will
short.
grow back. Yeah. Correct.
It will
Correct.
grow back
Correct.
and it might grow
Yeah.
back even better looking than the previous hair. I
Yeah,
don't know
correct. Exactly. Before this hair all white, then after chemo, the hair
why.
go back all black.
Why I want to ask, right? When I studied in Form 6
Yeah.
about genetics and curly hair and straight hair is, genetically
Yeah.
determined.
Jeanette.
Yeah,
Yeah.
but
Yeah.
I've seen patients, and even my mom, right, she went through so much, after her aortic valve replacement, she was so sick for a while,
Mm,
and then her
mm.
hair grew back all curly. So don't tell me she mutated. I don't understand. I've seen patients with straight hair after
Yeah.
chemo. grow back curly also. Then for
Really, yeah. It's so
this,
funny.
I think it's grown. Okay, is there any question? There is a question.
Yeah.
Uh, can you read? Because I don't know what happened. Hold on. Okay.
What is it? No,
Now
yeah.
ask, what is the interval duration of ultrasound breast in patients less than 40 with no risk factors?
I'm sorry, what?
What's the duration? How often do they need? If they don't want to do mammogram, I take it, Radhika. If you don't want to do mammogram,
Yeah.
so how often if you're for less than 40 with no risk factors, no family history?
Okay, so those less than 40 with no family history, they fall under the general population. So actually, our general population risk is not that high. So those less than 40, I would still recommend ultrasound, but you can do it 2 yearly. You can still do it at 2 yearly actually,
Hmm.
especially when you don't have risk factor, you don't have family with cancer, and you don't have the gene. You can still do 2 yearly ultrasound.
Okay, Dr. Adelina from Docuity asks, when is a vacuum assisted biopsy indicated?
Vacuum assisted biopsy is usually we do for very tiny lesions. So I do have several colleagues that actually do vacuum assisted biopsy. So especially those are like the tiny lesions, the microcalcification, the 5 mm ones, you can actually do vacuum assisted for that. So you suck out all of the microcalcification, you leave a marker behind, and then you send the specimen for testing. So unfortunately, in some way, we don't do.
Okay, so there are some
Yeah,
more questions coming
yeah.
in. Dr. Sari Rajan asks, advanced ultrasound or 3-day mammogram is advisable for patients for early detection and referral.
Yes.
No, it's a question.
Which is
Which one?
advisable for early detection?
Yeah. Yes, that's right.
So, like I say, those 40 and above, I still recommend mammogram first. Ultrasound is complementary. So, if mammogram can't see anything, especially in dense breast, then you would want additional ultrasound to check whether there's any mass or lesions in the breast. So, but for those 50 and above, not so dense breast, a standard mammogram is enough for screening.
And sorry, how much is a mammogram? Huh?
Mammogram, I think in some ways about 400 plus.
It's not that
I,
expensive.
I'm not sure about other hospital. I think it's cheaper in other hospitals. Yeah. And it's not that expensive. Yeah.
Yes, it's not that expensive
Yeah.
because
Yeah.
and I think I mean it's life saving,
Mm.
okay? Unless you don't want to know lah. A lot of people are like, oh, I don't want to know, I don't want to know.
Like I said, denial, they don't want to know.
Ah,
Right.
that's right.
Yeah.
So there are people who are like that. Uh,
Yes.
so now I'm sharing the CPD points, how you're going to get it and the e-cert. And from next week onwards, or maybe not next week, maybe next month, we're going to give the e-cert immediately from the website. I'm going to try it out. Actually, I can try it out today. I can try it out last week, but
Yeah.
as usual, it's scary. For me to try it, it's a bit scary. Adele
Right.
Time from Facebook asks, if above 40 with dense breast, can I skip mammogram and just do ultrasound?
So I think I mentioned just now in my slide, even though dense breast can't see lesion mass in the mammogram, we can still detect microcalcifications on the dense breast on mammogram. So microcalcification is an indicator of PCIS. So at the end of the day, I still recommend to do both ultrasound and mammogram, especially those with dense breast. It's a
Yeah.
good question. A lot of people ask. So yeah. So unfortunately for them, if you have dense breast, you have to do both every
Oh,
year.
I see. And
Yeah.
this, um, Yeah, don't be too scared of the pain of mammogram. Neither, you need to know the truth. So,
Yeah,
and you need to accept the truth. And it's a curable disease these days. Dr. Priya
yeah,
from Prokriti asked, I think the worst patients are the worst in healthcare. We often forget the importance of screening and be denial if the
yeah,
there is
yeah,
a lot also lah. Some like diabetic I see
yeah,
don't statin
yeah.
and then I had
So yeah. So one thing I would want to highlight to everyone is that whenever a patient come to you with a breast symptom, if the scan come back as negative normal, don't scold them for coming to see you.
what
You should reassure them that it's actually a good thing that the scan came back as negative normal. So
what does that
I
mean? People scold
yeah,
patients.
yeah, yeah. I had some patient who told me that, oh, before this, he went to some clinic or hospital with some breast pain, and she got scolded by a doctor for because the
That's
ultrasound came back as
ridiculous.
normal. So,
Yeah.
so
It is
um,
you must and pain, I think a lot of people think that pain is um an indicator of cancer. Actually, it
yeah,
okay, lump is an indicator of a cancerous growth, but not pain. Yeah, not necessarily have pain until it's quite advanced, then only you will have pain.
yes. So I have pain is actually not an indicator. If you see from my slide, pain is not an indicator of breast cancer. So many patients come in with pain, but the scan came back as normal. So pain is actually it's part of the menstrual cycle. You know, when you're about to have your menses, the breast swells up, then you would have some pain or discomforts. That's very common. But when they come to you for breast pain, just do the imaging. If it's normal, just reassure them. No need to scold them.
Yeah, yeah. But what I want, we need to send home a message is a lot of patients come. I say, why you come so late? Because there was
Yeah,
okay. So
yeah,
no
right,
pain,
correct.
but if there is a lump, be very
Yeah, yeah,
okay. Dr.
yeah.
Wong asked from Dr. T, if patient is 50 years old, had a lump over the left breast, 2 times 1 clinically,
Mm,
mammogram was normal. She had
yeah.
history of breast cancer. Is it advisable to remove the lump?
Personal history of breast cancer or family history?
No, family history.
Okay, the thing about many patients with breast lesion, they when I tell them reassure them that it's benign, they would want to remove it. But you have to remember, removing a benign breast lump doesn't eliminate the risk of breast cancer. So for your family or relative who has a breast lump, removing that benign breast lump doesn't mean that in the future she will not get breast cancer. So my policy is if you have a benign breast lump, it gives me more excuses to examine you more and monitor you more and detect early cancer better. So that's why I do not remove a benign breast lump, especially the small one. Unless it's very big, then and it's still suspicious, then yes. Or the lump is giving the patient problem, then yes, I would remove it. So if the patient doesn't mind coming for surveillance, ultrasound to monitor the lump, I would be more than happy to monitor the lump and also to screen the patient for the breast cancer rather than removing the lump and the patient go home happy. After 2 years, get a breast cancer on the other side of the breast.
Yeah.
Yeah.
It's not predictable. And
Yeah.
so because she has family history, it is better not to,
Yes.
yeah, to
Yeah.
actually screen on a,
Yeah, because if you have family history of breast cancer, it means that you are at higher risk of breast cancer, then you should screen your breast and monitor your breast more diligently compared to the normal population, rather than removing the lump and be happy with it. So that's one message that I would like to impart also lah.
yeah.
Yeah. Mm.
So I think that you won't be out of job for sure. And it is a very important topic because
Yeah,
half the population of this world are women,
yeah,
okay? And every woman have 2 breasts, means that there are,
yeah,
what, how many billion breasts in this
yeah,
world?
yeah.
So,
And breast cancer is actually getting more and more common. I keep getting patient coming in saying that some of the relative friends who get breast cancer. So it's getting more and more common.
And then it's getting earlier.
Yeah.
We are seeing breast cancer at an earlier age.
Yeah, earlier age, yeah.
Yes. So the take-home message here would be, of course, to screen yourself,
Yep.
self-examination, then eventually if you're more than 40 to do a basic
Mammogram.
mammogram or an ultrasound. And
Yep.
then when the treatment, if, touch wood, if the diagnosis is made, speak to your healthcare doctor and don't be too scared about the treatment, because the treatment is very different. Every year, every few years is different, right?
Yeah. We have every year I keep hearing newer and newer medicine being introduced. So we do have a lot of arsenals, a lot of medication to treat breast cancer. It's just that some patients may, they refuse because they hear the word chemotherapy.
That's right.
Or financial because the medicine are very expensive. Yeah.
This chemotherapy, I had a patient who didn't want to do chemotherapy, and the only worry she had was because she's scared that she will throw up and lose her hair. And then 2 years later, she had a recurrent. And then
It's quite sad. Yeah, correct. Then I have patient, very small lump is very small lump detected on a incidental, but unfortunately it's triple negative. And she was like saying that, why do I need to go for chemotherapy if the lump is very small? So, it's quite difficult to convince patient to go for
it's almost
chemotherapy.
impossible. It's very difficult to convince patient.
Yeah.
They have made up their mind about not having chemotherapy.
Yeah.
So if you imagine the breast cancer, now we say breast cancer, you just imagine the breast cancer to be a disease that could be staying dormant in any part of your body, right?
Yep.
So, but it starts with the breast. So
Yep.
if we take out the breast lump, that dormant cell is already can be in any part of your body. The
Correct.
chemotherapy is to kill wherever.
All the dormant cancer, correct. Yes.
So I think with that, I'm going to end the session. Thank you very much, Maywan. I see you again.
You're welcome.
And
Yep.
then, bye.
Bye-bye.
Next week,
Yep.
I think we have a session with Felix. Spot diagnosis in dermatology. We haven't had one for a long time.
So
So,
you have to remind him, don't take photos of
yeah. No private, but
no private part.
this this Facebook tell you it's crazy.
Yeah.
Yeah. Okay, bye guys.
Bye-bye. Yeah,
Bye.
thank you. Yep.
Hey, thanks, everyone. Bye, Jeff.
Yep, you're
Bye
welcome.
for now.
Bye-bye.
Thank you. Bye.
Yeah, bye-bye.
Bye. Oh, stop recording.